Hi, I'm Sandra Davis. I'm a psychiatrist here at UNT Health Science Center in the Department of Geriatrics. And I am going to be talking about behavioral manifestations of mental illness and dementia today. I would love to get questions as we go along, and don't hesitate. If you do have a question, either put it in the chat and we can discuss, or just unmute and we can discuss as well. I want this to be as interactive as possible. And it's always hard knowing exactly what challenges everyone is going through. So I know Barb Hardy, who's at the nursing homes frequently, is emailing me or asking me questions. So I'm hoping that you guys will do the same. So we'll go ahead and get started. We're going to be talking about in the framework of the 4 M's, which is a way to help think about our complex patients and what matters to them as far as their mobility, their medications, and their mentation. Of course, we're going to be dealing more with the mentation aspects today and some medication as well. The learning objectives are to kind of review some of the classifications for cognitive disorders, and also discuss the stages and the progression of the diseases, and some common behavioral problems that we see with dementia. I'm sure, if you're in a nursing home, you've seen these frequently. And then we're going to discuss some non-pharmacologic as well as pharmacologic strategies. And I want to hear from you guys what you're using and what's working in terms of treatment strategies. So we'll get started here. I'm going to talk about first the risk factors for dementia, which some are modifiable risk factors and some are not. Of course, when we think about some of the not modifiable risk factors, the most common ones are age, genetics. So age, as far as, what we see in terms of prevalence, the older you get, obviously, the higher your risk is for dementia. And then genetics. If you have a parent or a sibling that has Alzheimer's, your risk of having dementia is significantly higher. This risk is separate from the risk of some genetic markers that we are able to look at. So some people may have heard of the ApoE gene risk factor, and as when you look at genes, there's different alleles, and the ApoE gene has different alleles. Basically, you can have 6 different alleles. The ApoE4 is the strongest risk factor for having Alzheimer's disease. If you have 2 alleles of the ApoE4 gene, then that increases your risk about 8 to 10%. If you only have 1 allele, it increases your risk factor about 2 to 3%. And then the ApoE2 allele may be a protective factor. It seems like in comparison to the ApoE3 and 4, there's a decreased risk of having some kind of dementia. In terms of modifiable risk factors, things that we can do to help from getting dementia, there's physical activity, smoking, managing of hypertension, diabetes, and even, dietary risk factors. And then I should put in there too, probably depression. Depression increases your risk of having Alzheimer's. Okay. So in terms of classification, the classifications have changed somewhat, but basically we look at mild, major, and unspecified neurocognitive disorder. So a mild neurocognitive disorder means that you can have some of changes in your memory, but not necessarily changes in your ability to function because of memory problems. Oftentimes the cutoff between a mild and a major neurocognitive disorder is not very clear. And so that's where having patients come to see us, a geriatrician or a psychiatrist or a neurologist or a neuropsychologist, can help determine where those cutoffs are. But we do look at specific areas in terms of memory and concentration and focus. If someone has a mild neurocognitive disorder, sometimes it can be reversed. In other words, that doesn't mean they're going to progress to a major neurocognitive disorder, but for example, if they're having depression or if they're having other problems that are affecting their memory, once those problems are treated, sometimes they don't progress. But once we determine that there is a major neurocognitive disorder, usually the progression continues. So we're looking at, what kinds of diseases are causing the dementia. And I listed here a few diseases that we look at. Some people, obviously the most common is Alzheimer's disease, but there's also the vascular type dementias, and we often see them in combination with Alzheimer's disease. And then there's FTD, frontotemporal dementia, Lewy body, HIV. Some people have had traumatic brain injuries. I think that's in the media right now pretty frequently with these football players who are having early signs of dementia. And there's, a lot more. Prion diseases are kind of we don't think about these very often, unfortunately, but they can happen. And usually we see a more rapid progression of dementia with the prion diseases. And then for unspecified, there might be another medical condition that is causing the memory problems, such as Parkinson's or alcohol or Huntington's disease. So there's a lot more under those categories, but we do, try to determine as best we can what might be causing the symptoms, because the way the diseases progress might be different, and some of the treatments might be a little bit different. So let's see, in terms of progression, one thing that's really come to light recently are we're trying to pay more attention to now is that even before mild cognitive impairment or dementia is determined, there may be no symptoms of dementia present, but that doesn't mean that there aren't changes going on in the brain that may progress to the point of having a dementia. So sometimes patients will say, I feel like I'm having memory problems, but they don't really meet criteria for MCI or Alzheimer's disease yet. So those are what we're looking at more now in terms of trying to determine what could be causing those memory issues. And we're even doing research now to have some blood tests to see if we can try to determine what are some early markers in the blood that might point us in that direction. And why this is so important is because we know the brain changes are happening. And if we can prevent those brain changes from happening early, then hopefully we can prevent the disease from progressing. I also put on there so you can see different stages of the dementia. We have mild, moderate, and severe. So in the mild stages, there may be symptoms, but they're not necessarily interfering in all of the day-to-day activities. Like, for example, a patient might still be able to dress themselves and take care of themselves, eat, and do all those things. They may not be able to take care of their finances, or drive, but they can still do, most of their daily activities. As the disease progression, there's going to be more problems with taking care of their ADLs or activities of daily living. And then when they get to severe stages, that's when they're mostly impaired and having to get additional support. So let's see, when we talk about behavioral symptoms associated with dementias, and these are the ones that I see typically, we're going to see some delusions and hallucinations. The delusions, the most common types that we see are the persecutory type. Somebody's coming after me, they're trying to take stuff from me, or they're trying to hurt me. And then we also see one that's called Capgras syndrome, which is the imposter syndrome. That's one where somebody's been, their loved one is no longer their loved one. They're an imposter. And then also we see visual, auditory, tactile, and sometimes we see gustatory hallucinations, where taste hallucinations, where they taste something that's not there. With the tactile hallucinations, usually we look for other causes, and even the visual hallucinations, we look for medical causes for those because they're not as common as the auditory hallucinations. But for example, tactile hallucinations, a lot of times it's drug induced. So we look for medications that might be causing those. And then for other behavioral features, we look at depression, anxiety, sometimes mania, aggression, apathy, which is, they don't want to do anything at all, or just kind of just not having any desires to really interact. We have patients that have a lot of disinhibition, where they're the little part of your brain that says, no, don't do that. They just do. And so but what their loved ones see is personality changes. They're not themselves anymore. They're starting to do things that they wouldn't normally do, like maybe hoarding, or maybe more sexual activities, or sometimes even, spending money that they wouldn't normally spend. So just behaviors that are out of character for them. And then, of course, we see the wandering and pacing, and a lot of the changes in sleep. So those are the ones that we are trying to address, so that we can make the patient more comfortable. And I just kind of saw this chart, which I think breaks down the types of agitated behaviors that we see. And these are a lot of the ones that we see in the nursing home. So they're basically broken down into verbally non-aggressive, the verbally aggressive, the physically non-aggressive, and the physically aggressive. Without a doubt, the physically aggressive are the more harmful and concerning types of behaviors. But when you look at overall the types of behaviors, a lot of times the verbally aggressive ones are the ones that become the biggest complaints. And so, because we don't see the physically aggressive as often. So we get a lot of patients with the verbally aggressive ones, and those are the ones that especially family members are become very upset with. So in terms of looking at how to approach these behaviors, and this is kind of a complicated chart, we don't have to go through all of it, but the main thing to know about this is, first we have to determine, is the patient at risk? Are they going to hurt themselves, or are they going to hurt someone else? And that, that's the first thing. And trying to find a way to get them out of harm's way. So in these types of patients, we might use some kind of drug treatment to help calm them down. And while we evaluate and find out why, is this a change in behavior? What is causing this change in behavior? Is there a medical cause? Sometimes, they can have an infection or be in pain. And so we have to determine how do we address it. If there is an acute change in behavior, we need to roll out a delirium, which is, acute mental status change. And again, besides infections and other medical problems, we also look at drugs. Are they taking a new medication that might be causing a change in their mentation? We also look for depression and anxiety and, consider some kind of antidepressant treatment for the patients. And then, with sleep disorders, again, that can be multifactorial, what are causing the sleep problems, but oftentimes, just the disease itself is causing a change in their sleep pattern. So we try to address that the best we can. Sensory deficits are also a big cause. So want to look at, are there any vision changes? Are there any hearing changes? And that increases the risk for them having other problems like hallucinations and behavioral problems. And then this chart continues, but again, the ongoing issue in terms of maintenance is, once the initial change in behavior is noted, and if we do try a medication, then we have to reevaluate very shortly within, a month or maybe 2 or 3 months. Is the medication helping? Do we need to change the medication? Do we need to stop the medication and see, if the symptoms are better without the medication? So, and we're also at the same time trying to use other methods of how to deal with the problem, any, non-pharmacologic methods. So that's the short of it. So for non-pharmacologic treatments, there are, for mild to moderate dementia, there are some memory trainings that we can do to help with some of the progression of the memory problems. Sometimes that helps slow down the disease process. There's also music therapy. We try to decrease stimulation as much as possible. So using special lighting or removing mirrors and loud noises as well. And then there's also aerobic exercise to help in combination with non-aerobic exercise that helps with it doesn't prevent the illness, but it may prolong. So, keep the illness from getting worse as quickly. And then staying social, we already know that staying social is very important. Giving clear and repetitive instructions. Sometimes they need, multiple times to hear the instructions to know exactly what they need to do. And using pet therapy. And then there's a lot of caregiver support that we have to take into account because the caregivers don't know how to help their loved ones. So we have lots of great programs to help with that, thankfully. Any questions so far? No? Okay, we'll keep going. So in terms of pharmacologic treatments, the main thing is we start low and go slow. So with all of these patients, I look at it in terms of quality of life. And I talk to patients' family members about quality of life too. How do we want to help the patient have the best quality of life under the circumstances? And I know that, and this is one of the things that we're going to talk about today, is the risk of using antipsychotics in this patient population. There are risks obviously associated, and so we want to, lower the risk as much as possible. And when we talk to family members, that's basically what we talk about. What is the risk of the medication versus what is the benefit of the medication? One of the things that we look at is, heart. How is it going to affect the patient's heart? Are they going to be too sedated to function? Are they going to be able to interact with the family members? So those are the main concerns that the families have. And we address those the best that we can. We also use antidepressants, SSRIs, for depression and anxiety. We use buspirone quite a bit for anxiety. Trazodone we use for sleep and anxiety, as well as mirtazapine. And then for agitation, we use Depakote, which is a anticonvulsant that helps with agitation at times. For sleeping, we can also use over-the-counter melatonin, which helps regulate the sleep cycle. And then for people that have REM sleep behaviors, we can use benzodiazepine, clonazepam. In terms of what I mean by REM sleep behaviors is sometimes patients can have night terrors or nightmares, or sleepwalking, sleep talking, things like that. So that helps calm that down. All right, let's move on. Oh, I did want to say one other thing about the medication. So Lexapro hasn't been studied in dementia, but we have found that citalopram, which is one of the SSRIs, is effective in treating anxiety and depression in dementia. Both of those medications are probably first-line treatment in terms of this population of patients, just because they have decreased drug interactions. So, most of these patients are taking several different medications. And so those antidepressants are probably first-line treatment. We try to avoid anything that has a lot of anticholinergic effects, such as tricyclic antidepressants or Paxil. And then in terms of antipsychotics, we try to avoid some of the first generation antipsychotics like Haldol. We use Haldol mainly for treatment of delirium and not necessarily for dementia. The highest mortality rates with antipsychotics have been associated with Haldol, and then followed by risperidone, and then olanzapine, and then Depakote, and then Seroquel. So we try to, minimize risk by using the least likely to cause any types of mortality. All right. So basically what it boils down to is, we try to detect and treat to prevent progression of the disease. I didn't really go into, treatment of the diseases themselves, because that's a whole nother topic, but, trying to treat the disease early, and hopefully with some of the newer medications that are being tested today, we can try to prevent the actual disease progression. We're not there yet, but I think within the next 5 to 10 years, we'll get there. And then we look at symptom management. How can we decrease the amount of symptoms and increase quality of life? And we have to look at the risk versus benefits of the medications when it comes to reducing those symptoms. And we also use all different kinds of approaches, not just pharmacological approaches, but also non-pharmacologic. So, any questions so far? before we get into the discussion questions?
I was just going to say the other thing with early detection is not just treatment medication wise, but the education piece of things. I think folks that get earlier connections with the Alzheimer's Association or just earlier diagnosis for validation of the symptoms that they're seeing themselves or their loved one can be of a benefit to basically adapting. I think the folks that have the hardest time, in my experience, are the spouses, because they've known that person the longest and they expect a certain personality and a certain behavior. And when that changes, they take it personally.
Yes.
It becomes very challenging. So I think getting, just educational interventions and supports, in place early is also a big benefit.
Of course, absolutely. And sometimes it takes a while to get to that point. It doesn't happen overnight because sometimes the family members aren't really ready to accept that. So it may take several visits or longer to get to that point where you can, let the family members digest what's happening. It's hard. And then there are some patients who are, really proactive and helping themselves. And those are the ones that, they want to know everything that there is to know and try to address it the best that they can. So we love those patients that are wanting to get all the information and try to help themselves.
So we threw first of all, thank you so much for sharing the content today. And I'm not sure where the folks that we have in our audience today are coming from, a nursing facility versus like assisted living or memory support. But we would just love to hear from you guys with regards to what kind of challenges you're having in your building with dementia, persons living with dementia and behaviors. What kind of things are you doing to address those behavioral issues in your facility? So now's the time to unmute and just kind of share what's going on at your building.